I feel so moved by Adrian and Beth's both of their introductions to this meeting, because I think, we get lost in our own worlds, and we like to think that we're making a difference, and we always try to. But you are really the tangible, the visible manifestation of what happens when you just sort of try and work at a problem, and then you come at it from a different angle. And I think we all want to make a difference, and you as well as me. So it's really tremendous to see the audience today. What I'm going to do here is I'm going to just kind of give you my own odyssey. So each of you in the audience has a story as well, and all those stories are incredibly important. And I hope in doing this that I'll give you a little bit of perspective from my point of view about where we've been and where we're going as we face the future. So my story kind of starts in 1990 when I was called to our hospital nursery to see a baby with Dandy Walker malformation and this extensive hemangioma, which, and I was told this patient had SturgeWeber, which undoubtedly many patients with PHACE in the past were diagnosed with. And you can see here a very extensive and severe facial hemangioma involving both sides of the face and the scalp, ulceration, which we will often see in this setting. And this is just a photograph showing this large area of the back of the brain, which is the cyst that this child had, which required shunting. And also a very, very large area on the body. So this child had what we've come to call large segmental hemangiomas, including the face, ulceration. And unfortunately, her course at the time, we really did not understand why. She had a lot of shunt issues related to the need to take the fluid away from the brain of this large area that was putting pressure. And she did not do well, and she was really losing function, and ultimately she died, and I don't think we really ever understood why. And so this particular story had a rather sad ending, but I have to say a very unusual one in our experience for PHACE. So were we seeing something new? Well, actually, I remembered back to 1983 when I was doing part of my training with a woman named Nancy Esterly, who also is, in her own way, very responsible for the fact that you are all here in the room. And she's a person who trained myself, Dr. Garzon, Dr. Drolet, and then many of the people who they trained went on to be very involved in this. And I remembered this, and I called her up and I said, do you remember this case? We used to round on this patient in the hospital 3 times a week, and she had a big hemangioma. Did she have Dandy Walker by any chance? And she said, yes, actually she did. So we couldn't find any evidence initially of this in the medical literature using the usual search strategies. But if you looked at patients who had Dandy Walker, a lot of them turned out sort of hidden in the tables was the fact that they had hemangiomas. We thought, wow, this really probably is not a coincidence. And so we reported this in 1993, but we didn't call it PHACE, and we didn't really pay attention, although in hindsight, we figured out that many of these patients had other issues as well. And then in 1995, a couple years later, I saw this child, and they called me. They said this child seems like she's had a stroke in utero, in the womb, and she's got some neurologic deficits, and she has a large vascular abnormality on her face. And I said, oh, does she have Dandy Walker malformation? And they said no. And so this is, again, this cyst, and I was like, huh. So they said, we know she has arterial anomalies. So that made us go back and look at the cases that we had originally reported in 1993, and we thought, oh, we kind of missed the boat here. We were focused on these Dandy Walker cysts, which are very dramatic and often present very early on and need surgery. But we missed the fact that there were these arterial anomalies. So with the help of a medical student who had by then become a dermatologist named Bill Reese, we went back and we looked carefully again, and we found that when you look back, before 1985, there were reports of this. In 1985, a Spanish neurologist named Pasquale Castro Viejo, he had actually reported the intracranial abnormalities with capillary hemangiomas of the face. And in fact, in Spain right now, he, at least, and some of his colleagues refer to FACE as Pasquale Castro Viejo type 2 syndrome. He actually has another syndrome named after him as well. And so, you know, you could argue about whether that might be what we should be calling this conference, the Pasquale Castro Viejo Syndrome 2 family conference, but it doesn't roll off the tongue as well as FACE. So I think most of us are going to probably stick with FACE. And I don't feel defensive saying that because I didn't name the syndrome after myself, so I don't think I have to really apologize for that. But in 1996, after this case, we said, you know what, we should be able to connect the dots here. And in fact, we did try to connect the dots with this acronym FACE, as you all know. So that was published in 1996. And then the next little step, I would say, is exemplified with this young woman up in the corner here, Denise Metry. So Denise Metry was a pediatric dermatology fellow in Houston, Texas, and she came to spend a month with me. And she was a ball of energy when she came. She worked so hard, and she said, I'm really interested in this FACE thing. And I said, okay, well, why don't you see if you can find every article that was ever written that seems like using these various search strategies. And she was able to find 116 previously reported cases, and then she and I putting together cases that I've been collecting since we had started this odyssey. We had 14 new cases, and we reported these as the many faces of FACE in the Journal of Pediatrics in 2001. And as you know, Denise Metry now is the person who's in charge of the FACE registry, and really, I would say, pushed me into being more involved other than just the sort of original article, and has been a really great collaborator. I don't know if I don't see Denise here. Where are you, Denise? Way in the back. Anyway, very modest and very typical for Denise. So we believe that FACE is actually, once we found all of these references, we started to think, you know, this isn't the rarest of the rare. This is uncommon to rare, but for me, rare is something that I've been a practicing pediatric dermatologist for more than 20 years. It's something that I've seen maybe once or twice or three times in my career, not something that I see several times a year. So this, for a referral center, is what I would consider to be uncommon to maybe rare, but not very rare. And we do feel that, and we have evidence that this is as common as SturgeWeber syndrome, which is obviously much better known. So is it new? I think if I were a parent, I would look back and I would think, you know, is there something in the environment? Is there something in the milk that we're feeding our kids, or a pesticide or something that might be making all this happen when it never happened before? And I will have to tell you that as best as we know, the answer is no. That what we think has happened is that it was definitely, we can go far back and find cases, but they were called atypical SturgeWeber, and they were probably overlooked. And until you connect the dots and recognize something as a whole, you don't really see it as it is. You sort of don't connect those, make those connections. And so I do not believe that FACE is new at all. And I don't think that we even have evidence that it's increasing in incidence. So that's, but it really requires an astute parent or clinician and an awareness of this. And so I think what is new is increased recognition. As you all know, one of the most defining aspects of this, and I won't go through every single piece of this, is the concept of having a segmental hemangioma. Now, you know that hemangiomas in the population, you probably know, are quite common, but mostly what we see are these small localized ones. That's what most pediatricians see. They're not so used to seeing these ones that cover a territory, and this would be one of the common territories involved in FACE. And a lot of our work has been defined at who is really at risk. And nearly all patients, and if you use consensus criteria, all patients with FACE have facial hemangiomas. And these patterns are known to arise from the part of the fetus that's called the neuroectoderm, which is the part that gives rise to the brain and gives rise to the skin and certain parts of the eye and various other parts of the body. But not so much to the blood vessels, although there's some very intimate interaction of the blood vessels in the face in particular with the neuroectoderm. So these patterns do tell us something about the fact that this seems to be at least in some component, a neuroectodermal process. And we actually, Nita Hagstrom, who's sitting in the front, was instrumental in tracing out these patterns. And this particular segment 1, which is so common, is something that really was not recognized before as a distinct pattern, but it's very common in FACE. We're still learning about patterns. We're going to try and map the scalp patterns, which we think are quite important, actually, probably in FACE. What do those patterns tell us? They tell us something about when this defect, this developmental abnormality, might actually occur, because these patterns occur at a certain point in the growth of a fetus, very early on, actually, at 4 to 8 weeks of gestation for the most part. So we believe that whatever happens that leads to FACE is probably something that happened before most of you maybe even knew you were pregnant, or you barely knew you were pregnant, and something went awry. We don't yet know what. We're certainly interested in looking for this. And so although the hemangiomas associated with FACE are not necessarily noticeable at birth or barely noticeable, we do think of this as a birth defect. This to us is clearly a constellation of findings that are a birth defect, and likely one that has very early embryologic origins, and it's not the forceps that got put on the baby's face when they were coming out of the womb or anything like that that can be blamed for this. We also know, and this is something that sometimes other doctors are not so good at, that we don't consider this child to have 45 hemangiomas, that you sometimes do have to, in your mind, connect the dots, and that this is a collection, but it's over a territory, and many times you will see this kind of finding in patients with segmental hemangiomas and with FACE. And often, actually, interestingly, in association with like this and then nothing more than just lower lip seems to be a pretty common pattern as well. And this is just another example of where the hemangioma may be bulky deep, but then there's this very faint area, as many of you know, these areas that even barely develop or proliferate. And as many of you know, that you can see patients who have these precursor lesions that never, in fact, fully grow, and that can still be really the hemangioma of FACE. And that's harder for a lot of people who aren't experienced to recognize, but we do know that that happens. So how do we define FACE? Prior to 2007, there really was no standard definition. People mostly said, well, if you have a big facial hemangioma and you have any one of the other things, that sort of is probably FACE. But it was certainly too restrictive to include all of the features, because virtually no patients, or very few patients, have all of the features. But we felt that it was too broad of a definition because we were including abnormalities that are pretty common in the population. And so what happened in 2008, thanks to Denise Metry and others, was we held our first workshop, this being the second today, devoted to FACE. It was held in Houston, Texas, and the first family conference. And basically, Denise and Beth forced a group of us to sit in a room without taking breaks for hour after hour after hour until we could agree. This was the confinement torture method. No, that's a joke. But we sat there and we said, can we really work this out? We need to do this. For one thing, in order to study it better, in order to do better genetic studies, as Dawn Siegel will speak about. And the medical workshop was attended by about 100 physicians as well. But a smaller group helped to define the diagnostic criteria. So as you know, and you'll hear more about this later, we created diagnostic criteria into minor and major criteria and possible FACE syndromes, patients who maybe have it, but you can't quite say for sure. And this is very traditional in medicine. If you don't know the cause of something, you use these kind of criteria where you say one of this plus two of that. It's just very much the way medicine is practiced these days. And then this was published later in pediatrics, and I won't go through this, but just these are the criteria that we now use. So what are some potential problems with the consensus criteria? It certainly can be overly restrictive. We didn't want to be overly inclusive, and the importance of not being overly inclusive is really related a lot to studying patients. If you're overly inclusive, it may make it much, much harder to look at genetic studies, because in looking at genetic studies, you're trying to find very specific common patterns, and if you add too many patients who might not really have FACE, you'll kind of muddy the waters and make it harder to study. But on the other hand, were we too restrictive in the sense that I believe that we have patients who have chest arm and neck hemangioma without a facial hemangioma, who have all the typical arterial anomalies of FACE, and probably do have FACE, but under our current definition, they would be called possible rather than definite FACE. But I think you have to start somewhere. And ultimately, we recognize that there may be limitations, and once we do find the cause, and I believe that we will, or causes if there's more than one, we will be able to redefine this based on that information. And that's very common for what's done in medical knowledge. So FACE, we know that this is a dynamic process. It's now well recognized, but we certainly don't know the cause. And we know what the key features were. We knew them as we defined them, but we're still finding out so much more, and this conference is one manifestation of that. So these are just recent examples of articles that have been published about risk, about intracranial anomalies, about the association of hearing loss, and these are all just in the last few years about the association of lower body hemangiomas with a similar syndrome that's not FACE, but that involves the kidneys and the spinal cord and other sites. And et cetera, on and on. And there have certainly been more than, well over 60 articles, I think maybe closer to 100 written. So what are the enduring clinical features with all the new knowledge? Female predominance, still unexplained, but definitely continues to persist. The association with infantile hemangiomas continues to persist, though not all are the classic proliferative hemangiomas, as I've shown you. The arterial anomalies continue to be perhaps the most important abnormality outside of the skin, and other structural abnormalities. We've learned a lot more about the specific aortic and cardiac issues. So where are we going? Well, one of the things we've spent the last day and a half doing is looking at further risk stratification. And what we mean by that is we now feel like we can diagnose FACE. We have consensus criteria. We can say your child has it or they may have it, but we can't say for sure. But even within that group, we know that there's some babies and patients, older children, who are mildly affected, who have a facial hemangioma that actually goes away, and they have one funny artery that's in their neck and going into their brain. And then we have other patients who have much more severe problems. And so it's important to try within the group of FACE to begin to separate those out. We're looking at prognosis, which is what all of you want to know. What's going to happen to my child? We're beginning to try and look at that more carefully now that we have definitions. We are trying to look at the interactions of abnormalities. Does it matter if you have an aortic abnormality? Does that end up affecting the outcome of your brain vessel abnormalities or not? We don't know the answer. Certainly lots of you have questions about the use of propranolol in FACE, which you will get to hear about later. We are interested in doing as many genetic and molecular studies as we can, including looking at tissue, not just at blood. This is going to turn out to be very important, I think, in trying to find cause. And, of course, you, the families who are involved, are going to make a huge difference, as has happened in many other diseases, because to the world this is still rare. To you, this is becoming more and more part of your lives and common, but you need to be active in making this happen. The keys to unraveling the mysteries. Interested professionals, I think you can see that there are many here. Motivated parents, all of you and more. Collaborative research, which we really have, I think, been very fortunate in having a group of people who are willing to collaborate and share and not simply try and work on their own. Money, which we always need for research, and I think a degree of luck, which hopefully we will get. Because Beth Drolet is a very lucky person, actually. And let me acknowledge a few people. Certainly all of you, Nova, the Hemangioma Investigator Group, Nancy Esterly, who I already mentioned, and all of these other sponsoring agencies. And last but not least, I just took this a little while ago. This is Beth standing in the PHACEing the Future t-shirt, which she immediately took off, but she's going to keep one for herself. So this is where we start today, the PHACE Family Conference, Milwaukee, Wisconsin, 2010, and thank you to Beth, when Beth and I get together, it's a little bit of a dangerous proposition because both of us usually end up going home with more work than we started with, but we really do love it. So thank you very much.
think what we're going to do, Dr. Frieden has to catch a flight back to the West Coast this afternoon. So we maybe have Roy collect any questions specific to some of the presentation that Dr. Frieden presented. And then, Anita, can you help me with, and as we mentioned before, we do have questions that came from the website. Okay. That I might start off with. So you spoke a little bit about this, but how common, what is the frequency of PHACE would be your estimate?
So, well, of patients, we do know the one solid piece of information we have, which was just published a few months ago in Pediatrics Journal, is that if you, of about 100 patients who we enrolled with large facial hemangiomas that were larger than 5 centimeters in diameter, about 30% of those patients will meet consensus criteria. So of patients who have large facial hemangiomas, about a third of them will have PHACE, whether in the mild, moderate, or severe end of the spectrum. So we do know that. In the general population, what's the incidence of that in the population is really not been determined. It's certainly, you know, the incidence of hemangiomas in the population, again, depends who you're looking at, but most people use the number 4%, and about 15% of the hemangiomas that come to a referral center are larger segmental hemangiomas. So you can kind of do the math from that. So it's going to be something that's not exceedingly rare, but not so. Probably in the less than 1 per 1,000, or maybe 1 per 5,000 range would be my kind of best estimate, but if that's a guess.
Any other questions at all? There's kind of a tough one I might unload on you before you leave.
Okay.
So one thing that came in a couple different ways, questions is, do we know anything about the life expectancy of children with PHACE? Is it different than?
I don't think that we know. I would, in general, I think that we would expect that the life expectancy of children with PHACE would not be significantly different from other children unless they have the very severe end of the spectrum in terms of things like severe seizures that might affect their life expectancy, because seizures can be life-threatening complication. Severe cardiac disease that might affect it. But so really at the severe end of the spectrum. I do work with not just children, but I work in a hospital where I'm working with neurointerventional radiologists who are seeing mostly adults with stroke and other cerebrovascular disease. And actually, Darren Orbach, who's from Boston, has been kind enough to be with us here too. And we've talked to him and others about this issue of, like, how many adults are coming in who really might have this, and it's not overwhelming numbers. And so I think that there are reasons to think that this is a kind of, we don't have a real answer for you, but I think that you should be relatively optimistic that this is not that this is not, for most children with it, going to be something that's an imminently threatening condition, and time will tell. As we develop more information, we'll be able to answer that question better.
Okay. Thank you very much, Dr. Frieden. Thank you, Pasquale.